Hello, everyone. Welcome to Doctor's Health Talk Show. I'm Dr. Farhan here, joining you from Philadelphia. Today, it is my pleasure to invite one of my close friends, Dr. Ankur Parikh. He is a oncologist, hematologist oncologist at Cancer Treatment Centers of America, and medical director of precision medicine at our hospital. So, welcome, Ankur. Thank you for joining,
Thanks for
and
having me.
I'm excited to see you. Because of the COVID-19, we haven't been seeing each other in the hallways, and life has taken a different turn. But thank you for joining. So today I'd like to take an opportunity to talk to you about your life story, because I find that there's a lot of moments in your life that might inspire us and new generation to follow the footsteps. So tell us a little bit about your life.
Mhm.
Why did you become a physician?
Yeah, that's a great question. I'm from Chicago and born and raised there, and sort of my training has brought me out east, eventually to Philadelphia here. But I was one of those, oddballs that I knew I wanted to be a doctor way back when I was in high school. So it really made my path easy because I didn't really think of anything else. And so what really, inspired me is as a student in school, in middle school, high school, I did have a couple of classmates that were affected by cancer, which sort of made me think about this disease as sort of something that really disrupts the person's life, their lifestyle, and it really impacts their family. And so I always was a little bit interested, like what is cancer and why does it do this? And so as I got to college, I did a lot of science classes. I was pre-med, and I got to medical school after 3 years. I did one of those direct medical programs. And when I was a medical student, we had the opportunity to do elective rotations, and I did a lot in oncology just to really see is this for me. And I was just so fascinated with the different treatments, whether they're for solid tumors, for blood cancers, the whole concept of even a stem cell transplant and seeing some foreign cells go into somebody and really help them, in a lot of cases cure them. It was just so mesmerizing and so intellectually stimulating that I said that this is really a field I want to be involved
So, Anchor,
with.
there's a few of things there are very they are surprising. As a parent, my parents, they told me I should become a physician, and most people with Indian and Pakistani backgrounds, their parents
Yeah,
are big influence. But
right.
did your parents ever push you to become a physician, or it sounds like you were into it, so they would be like, we don't have to push him
Yeah,
to
it's
become
actually funny
anybody.
because my sister, my older sister, she's a physician, and she knew early on she wanted to be it. And so my parents knew, oh, we already have one doctor in the family. And so my mother actually was wanting me to be a lawyer, and my father a teacher. But when I said I wanted to go
Wow.
into medical school, they were like, okay, that's fine. So,
That's very interesting. Yeah, because all of us mostly have been told to be a physician, and
right,
this
right.
is really refreshing. You went into oncology, but you started getting exposed to oncology in your childhood, maybe as your young
Mhm.
adulthood. How was that like? I mean, I've never encountered anyone growing up who had cancer until I was in
Mhm.
medical school. My neighbor got cancer. That was my
Uh-huh.
closest encounter. How was it
Yeah.
like to feel somebody, in that pain of cancer?
Yeah, I mean, you really see the impact that it has on your life. And so actually my father's brother was diagnosed with colon cancer back when, I was I believe I was in junior high at the time.
Hi.
And so, I mean, thankfully he's doing wonderful, today, but I really saw the impact that it had on, just on my father, on my cousins, and really seeing, firsthand what cancer does, and going through surgery, going through chemotherapy. And so that continued to, promote my interest in pursuing this.
Anchor, this is very interesting because I want to tell you, compare my life. What happened is we never saw the success stories in cancer
Mm,
up until very late. And
Yeah.
maybe one of the reasons that we were always scared of the word cancer, and even going into oncology, I remember in my residency, one of my mentors told me to consider oncology. I was afraid because I was like,
Mm.
I would never be able to be happy. And
Yeah.
I'm glad that you're sharing that, because your uncle had cancer, your friends had cancer, and
Mm.
you then got into look into it and was able to find the light at the end of the tunnel. You saw that you could make a difference, and that
Right.
made you, that puts you in a unique position to actually
Hmm.
take on cancer in with much more, force and optimism. So
Hmm.
um, talking a little bit about your training, so where did you go to medical school and your fellowship? Tell us about that.
Yeah, so I went to medical school in Missouri at the Kirksville College of Osteopathic Medicine. At the time, like I said, I knew I wanted to be a doctor, so I applied to a lot of these direct medical programs where you
Yeah.
would go to undergrad and from there get right into medical school. And so I did 3 years of undergraduate there and then at the university, and then went right to medical school in Missouri. And then did my residency in Columbus, Ohio at a community internal medicine program. And then at the time, that's when I did a lot of my elective rotations in oncology. I went to NIH, I went to MD Anderson, and so really got to see some high top level oncology care firsthand. And that also helped me establish relationships. And eventually, when I applied for fellowships, because of my experience at NIH, I knew that's where I really wanted to go, and I did my fellowship at the National Health.
So a lot of times when I talk to my friends, they talk about mentors in their life early on that help them, get into a career. It seems like you actually explored a lot on your own, and
Mm-hmm.
one of the benefits is maybe because you are uh, a born and raised American who knew the system, had the confidence, and reach out. But is there anyone in your residency, in your fellowship, that you considered a mentor that you still think that made an impact on your life?
Yeah, yeah. And so, I mean, I think a lot of credit initially goes to my family. My parents were always very supportive. I never had that pressure that this is what you have to do, but they were also very involved in sort of developing my interests and promoting me and putting me in positions where, as I work hard and have that drive that, I can succeed. I also saw my sister go through all of it before me, so I sort of knew what that path would take. And then once I got to my fellowship at NIH, absolutely, I had great mentorship within my own division chief, as well as a lot of other leaders there that would help nurture sort of our careers. Because at the time, a lot of people would stay in academics or stay in research, and I was a little bit different. I liked the clinical education piece and wanted to do more, of that. And so they were very supportive, with those types of.
NIH is a great program, and many scientists actually come through that institution. I want to ask you about your journey from becoming an oncologist. So it's a 3-year fellowship, right? Hematology and oncology, right?
That's right.
And then you you achieved what you had to achieve in NIH. You joined Cancer Treatment Centers of America in
Mm-hmm.
2012. So
Mm-hmm.
take us through that journey, and now you being the director of precision medicine at CTCA.
Mm-hmm. Yeah, so when I was at NIH, obviously it's a big academic facility, big research facility, top level stuff. And a lot of people, if they leave NIH, end up going to other academic, centers. So for me, I love that research drive, but I was really focused on clinical research, clinical trials, drug development, things like that. And I interviewed at various institutions, academic centers, private practice, came here to CTCA to interview. And what I was really drawn was I felt that this was a nice hybrid, of a community program, but sort of with the academic or, clinical research interest. And so there was a lot of interest in sort of promoting and putting young physicians in positions to succeed if they have the drive and the motivation to develop these type of programs. And so I was very thankful that once I started, I had that opportunity to start developing a lot of these programs, and then got to be the medical director for precision medicine a few years ago. And since then, I've really been able to lead the whole enterprise-wide program with great support behind me.
Thank you. So give me a little bit of what is your current area of interest in oncology? And my follow-up question would be how precision medicine is working in oncology.
Yeah, so currently my interest is GI oncology. So I see mostly patients with, esophageal, gastric, colon, pancreatic cancers. But precision medicine is really for everybody, and we can have a whole separate discussion, on this topic because it's really changing the landscape of cancer treatment, and it's also now starting to be a part of other specialties like cardiology and even primary care to some degree. And so with precision medicine, the basic concept is that, normally you treat all tumors the same, but the results can always be very different. Why did, one person respond to this treatment and somebody else did not? Because they have the same cancer, the same therapy, doesn't make sense. But with precision medicine, you start looking a little bit deeper into the tumor biology and realizing that a lot of these tumors might be driven to grow or spread because of various mutations or biomarkers or something. And are there specific targets that we should be looking at that's influencing the tumor growth? And so it's not a new concept in oncology, but it's really started to evolve. And now there are a lot of FDA approved therapies, that are based on specific mutations, not site of tumor, which
Wow,
is
that's very impressive. So
really,
we as non-oncologists know BRCA1, BRCA2, those genes, and after that we get stopped. Like we don't know what else
yeah,
are the genes that are there who can actually identify make one person different than others. And now we
right.
have been talking about like breast cancer, the estrogen receptors and whatnot. So
Mhm.
give us a journal on cancers or sites of cancers that have mutations that are now detected. Is it all types of cancers can be studied through precision medicine now?
Yeah, so there's lots of different ways to do testing though, right? So you alluded to BRCA1, BRCA2, so a lot of that is genetic testing, where
Okay.
basically you may meet with a genetic counselor, they go over your family history or pedigree, see if you might be predisposed to hereditary cancer syndrome, and then have that testing done. Genomic testing looks at what is the mutation in the tumor itself. And so currently, we're testing tumors that are advanced, like metastatic stage 4 or stage 3 inoperable. We're still finding the space in early stage curable cancers, but we're not, doing a lot in that aspect quite yet. But with precision medicine, a lot of national guidelines now, especially lung cancers, is the poster child of using genomic testing up front in these metastatic advanced lung cancers because you may identify targetable mutations, which likely could lead to potential responses.
Okay, now I understand. So you explained it really well because I was not getting to the gist of it. So I'm thinking most people are aware of viruses, and then we know viruses mutate every year, and
Right.
then we modify the treatment. So in this case, cancers cells
Mm-hmm.
mutate, and
Mm-hmm.
this genomic study can help us identify this type of cancer has mutated, and this treatment would work more effectively.
Mm-hmm.
And so it's not purely what you what your hereditary genes are, but actually the cell within it. How is that changing? So within one
Right.
cancer cell in one human life, can a cell
Mm-hmm.
change from 1 year to 5 years, or is it just one time you
Yeah.
just check them?
Yeah, no. So cancer can certainly evolve, and depending on the type of therapy that you're providing, it can become resistant to it. And so, one example that happens in lung cancer is, 90% of all lung cancers are directly related to cigarette smoking, but yet there's a portion of people that have never touched a cigarette and still develop lung cancer. So there are certain driver mutations, and one example is a mutation called EGFR, which could be seen in that type of patient where there's great targeted therapies that work really well to block that mutation and lead to great responses. However, with time, eventually the cancer becomes smarter and it'll create a resistance mutation. And now that treatment that you had them on is no longer effective and the cancer is growing. And so by doing genomic testing again or checking for these resistance mutations, you can try a different therapy that overcomes that resistance.
Okay, so are we testing these cells through blood or through tissue biopsies?
Yeah, both ways actually. Tissue biopsies are what most people are doing, just because you're getting the actual tissue itself. But with that said, blood-based genomic testing is really up and coming as well. And sometimes it's even easier because it's non-invasive. You don't need to put someone through a biopsy or a surgery or a procedure. It's literally just a blood draw. And so there's different roles of blood versus solid tumor, and we can go about when would you use one over the other, but to answer your question, absolutely.
Wonderful. So let me ask you about where do you see the future of precision medicine, especially when we talk about oncology, maybe 5 years, 10 years from now? What are the things that you are seeing that we may not know that might, more shed light on that this is the way path forward for
Right.
curing
So we're
cancer?
starting to understand that not all cancers are the same, and we're trying to identify patient populations that are likely to respond to therapy, or identify groups of patients that are not likely to respond to that therapy. So with precision medicine now, there's certain mutations that we know if a tumor has, it may not respond to immunotherapy, even though immunotherapy is, an FDA-approved therapy for their type of cancer. So we're getting more education about these specific biomarkers and mutations. And so where I see precision medicine, 2 years, 3 years, definitely 5 years from now, is now describing cancers, not necessarily from the site of origin, but really, maybe like a long list of mutations that it has. So you can see which are the treatable mutations, which are the resistant mutations, and then offer the best therapy, whether that person has lung cancer, stomach cancer, or breast cancer.
Okay. Now, there are always roadblocks to new therapies, new testing. What are the
Mhm.
roadblocks that you see that we need to overcome to
Yeah.
move forward?
No, that's a great question. And initially it was just doing the genomic testing itself. In the beginning it was considered experimental. It's expensive. What's the value that it's adding to the patient? And are you just going to now treat them with unapproved or unstudied therapies just because a sheet of paper says that this should work? So we're getting better in terms of clinical trials now. And so a lot of the clinical trials, basket trials, umbrella trials, are basically looking at specific mutations, whether it's in one cancer type or a variety of mutations in all cancer types. And that way, in a structured fashion, you can enroll a patient onto this clinical trial and give them a therapy which is monitored, in a very scientific way to see if it adds benefit or not.
Wonderful. So it seems like you're enjoying what you're doing. So
Mhm.
my question is, what was your dream of a perfect job, a dream job, and uh, how satisfied you are with your current situation, and where do you see yourself?
Yeah. Yeah. So I've always, been very inquisitive, and I need to know why, and I've always wanted to know that extra piece. And so this whole precision medicine opportunity is just exactly where I want to be. Just, the ability to test a patient's tumor and really understand the logic and the science behind it, it's so fulfilling. And then to be able to talk to these patients about potential options, I think we're still, learning a lot, right? So we're not trying to guarantee anything. Patients also need to understand, they may not have targetable treatment options, it's the reality. But they just are very happy, and it's really great to have these conversations where, especially people that have stage 4 cancers, that they may, go on Google and look at, poor outcomes and poor overall survival, and, have hope that maybe with some of these biomarker driven therapies or immunotherapies, if they're candidates, could potentially change that pendulum. And so that really keeps me motivated. And then you see certain patients do extremely well where they, 3 years ago would not have had that chance. And it just continues to drive, the fire to keep going and learning more, for these patients. And so the ability, to have that opportunity to offer these therapies to our patients, have these clinical trials, is very important to me. And then also have a great work-life balance, right? Because I think you have to have that to be able to do what you do well. And so I think
Yeah,
that's
to
very
avoid burnout, to keep yourself refreshed, and to give your energy to your brain and think outside the box.
yes.
As a, in CDCA, since we have an enterprise of 5 hospitals, do other oncologists use you as a resource to help, evaluate their patients, or everybody is doing their independent work?
Yeah, no, we try to keep it very organized, right? So we have our precision medicine committee. Every hospital has their own molecular tumor boards. And so we try to structure it so that things are essentially the same at each hospital. And if there's a question, if there's something that's going on, there's a path to get that answer. And so we really want to keep that relatively consistent.
You speak at national conferences on topics of precision medicine and oncology. Um, what are you seeing, and what do you share with people that helps other oncologists and physicians?
I think there's a lot of interest, skepticism, and questions about just precision medicine, because it's not as easy as, oh, we're just going to test your tumor, it's going to find this great mutation, and boom, I'm going to give you a therapy and it's going to work and you're going to be cured. That would be wonderful if that was the case, but obviously that's not the reality. And a lot of times, a lot of academic centers are doing their own in-house genomic testing. A lot of community programs don't have that type of structure, so they're using commercial tests. And a lot of it is just questions like, well, how do I even do that test? Do I do the biopsy like you asked me? Do I do a blood test instead? How do I interpret the results? How do I counsel my patients as to what this means? How do I know which therapy is the right one? So there's a lot of education that needs to happen, because this was not a class in medical school, as you did not have a class, you had physiology, you had cardiology, you did not
Yeah.
have precision medicine, you did not have genomics, so this is stuff that we're all learning, as we're doing this.
What um, share with us, Ankur, a event, a patient story, anything that made you strong, determined, resilient, um, and maybe give an advice to all of us as fellow physicians to keep
Yeah.
doing what we are doing.
Yeah, so I mean, one of the earliest examples of the value of precision medicine I saw was, 5-6 years ago, I had a patient that had stage 4 lung cancer. And we went through, one after the other, all the standard chemotherapies, first line, second line. Things would work for a while, then they would stop working. We'd try something different, it would work for a while, it would stop working. And she always knew, because she would start developing shortness of breath, this cough. She can tell me, Dr. Parikh, this is not working anymore. And lo and behold, we do a scan and she's absolutely right. So we got to the point one day where, we had a very honest conversation. I said, listen, there's this thing called genomic testing. We could try and see sort of, what could happen. Or, I get it. You're very tired. You fought this cancer for a very long time. You're on oxygen. You're not feeling well. We can go hospice. And I think that could be a very reasonable option for you. She was married. She had a granddaughter who was a junior car racer. And she's like, I'd like to still try and fight, if I can. And so we did genomic testing. She was found to have a mutation which uses a drug that we typically use in kidney cancers. And at the time, there was no clinical trials I could enroll her on, and she had no other standard treatment options left. And so, we pleaded to the insurance company. I told her quite honestly, listen, I will try this therapy if you want to. I don't know if it's going to work. I can't quote you any data, but if you want to, we'll do it together. And she said, absolutely, let's try it. And so every week she came for this infusion of this medication. And within 2 months, she's like, my breathing is better. And I'm starting to walk more. And I said, okay, let's not get too excited, but I'm glad you're feeling better. And by 3 months, she was now walking faster than her husband. And the color came back, and it was just so amazing to see this transformation. And it was getting to the point where she was due for a CAT scan, and part of me was like, let's not even do it, because look at her life now. Like, what if, what's the scan really going to help me? But the academic in me, and of course she wanted to know too. I did the CAT scan, and the radiologist actually called me. Normally when you get a call from a radiologist, it's because it's bad news.
It's a bad news, yeah.
There's new brain metastasis, there's new this, there's new that, some kind of urgent thing. He called me, says, you won't even believe it, but her cancer has significantly reduced in size. And we showed her the pictures, and we just were so amazed with how well this treatment worked for her. And we were able to keep that therapy for her for 18 months. So this worked for about a year and a half with great quality of life. And the story that she told me, this is what, to answer your question, what keeps driving me, is she was able to go to her daughter's junior race car event. And she was able to take a picture with her granddaughter. And she showed me the pictures, and she was just so happy to have that moment with her. And that just put it all in perspective, put it all together. And I'm like, this is why we got to keep trying something. And unfortunately, eventually the treatment did stop working. We tried a couple more lines of therapy and it didn't work. And she did eventually go on hospice, but she got an extra 18 months of not just, life, but good quality.
Good quality of life.
And of course, her situation may not be for everybody. Not everyone will have that same type of amazing result, but you have to keep trying. You have to keep asking, and you got to find the answer. And so I always think of her because she was one of my very first success stories in precision medicine that keeps me driven.
This is a very inspiring story. I've been working with you for about 7 years, and we share many patients together. I've
Mhm.
never told you on your face. Whenever I meet a patient of yours and I say, "Who's your doctor?" and we find out it's you, and we get into treatment, and they always say the same thing, that you're very honest with them, you keep
Mhm.
them updated, but you never give up. And
Mhm.
that's the story, that's the inspiration that I want to get from you today and spread it,
Mhm.
that as physicians we have to remain optimistic no matter how grim things look, and we have to keep thinking outside the box. Had you given
Right.
up on that patient that time, the story would have been much different.
That's
Nobody
right.
would have actually blamed you or said you
Mhm.
anything, because we understand. But how you made that 18 months different for her, it might be the best years of her life at that time. So
Mhm.
thank you for what you did, and thank you. I hope that you and your family and your crew member and your team remain healthy during COVID crisis. How's things with COVID for you at CTCA? How are things going along?
Yeah, I mean, as you can see, here I am in scrubs, so
Yeah.
that's the change number one.
th-
It's a different method, but CTCA is doing a great job of protecting patients, protecting the healthcare workers as well, and really streamlining things and keep things focused. So although it's a different way to take care of our patients, we're all on the same page. Patients understand, we understand we're doing our precautions really because safety comes first, but still offering them the same therapy that they would get if COVID wasn't around.
we are fortunate to be able to
Yeah.
work at an institution like this, because thankfully, so touch wood, it remains a COVID free institution. We were able to take care of our patients, give them therapy with the help of all our great physician team and administrative team. So thank you so much, Ankur, for giving me this time. We will dig in deeper into some fun aspect of your life in a couple of moments. Okay, thank
Sounds
you.
good. Thank you.